We are in the unenviable position, this panel, of coming right after lunch. So please, no snoring. So before we get started, before I even read the name of the panel, the title of the panel today, I thought I would start thinking about the sessions from this morning. I thought I would start by reading a letter that we got from from a participant of my study, an AIR study, on November 20th of this year. And he's in his mid-70s. He says, I'm currently in Oklahoma, or on Oklahoma's death row for a 1985 conviction. That experience has not diminished my desire to leave the secular world in a better condition than I entered. I am blessed to have retained most of my cognitive gifts. I was not one of your random selections for the study, but I'm willing to share my experiences to assist in the survey and to better understand the likelihood of developing a number of health outcomes. So I just thought that was a nice illustration of the desire of some of our incarcerated individuals to continue to learn and to participate in studies for a long time. So with that, I'm Susan Lapham. I'm Vice President in the Research and Evaluation Division at AIR. I'm also the Director of Project Talent, and some of you may know that I was the Director of ESSE for a number of years. And if you knew me in that position and didn't recognize me today, I have thrown away the box of Clairol, and this is my natural state. I encourage you all to do it. It's wonderful. So I wanted to say, before we introduce our panel, I did want to say a little bit about Project Talent. I think it's relevant to a lot of the work that you are doing, both from the sessions yesterday and today. And it's a very, hopefully, gaining more credibility and more exposure in the world, but it's relatively little known right now. But it is a 58-year longitudinal study of 400,000 individuals. 400,000. It's pretty amazing. And the original intent was to look at education and career outcomes. It began as a study of high school students in 1960 and continues today. We have a number of grants from the National Institutes for Health, and our current focus is looking on health outcomes, particularly memory and dementia. We have linked our data to Medicare, which may be of interest, especially to the folks on our panel today. We have a longitudinal data set that is available for secondary analysis. We've also linked to the National Death Index, so we have mortality information. And we've had a number of papers published this year showing that lower cognitive ability in high school is predictive of poorer health outcomes as people age. One specific example is that people who scored low in the lowest tercile in abstract reasoning in high school have a 17% greater chance of developing dementia as they age. So important work. Okay, let me turn now to our panel. So this is session 9, Skills, Health, and Unemployment of Older Adults. Our panel members include, we have 2 papers that will be presented. Our panel members include Takashi, Yamashita, and his co-authors, Anthony Bardo, Roberto Millar, and Darren. I think Darren is in the audience, not up here. And then a second paper that Phyllis Cummins will present, and her co-authors are Taka and Annabelle Arbogast. And then we have our discussant, Ricardo Hernandez, and he's an independent researcher. And just a reminder that the bios of all of our participants are in your packet. I'm also supposed to remind you that to write down your questions as the presenters are giving their papers, and we'll have time for questions at the end. And with that, Taka.
Good afternoon. I am honored to share my research with this outstanding audience, and I'm kind of feeling guilty to talk about preventive health after eating so much lunch, but I will have to do that, so please bear with me. The objective of this research is to kind of explore whether a specific numeracy scale cut point, so we have a scale of 0 to 500 and a suggested level of 5, but at what point would be useful information to predict older adults' preventive health behaviors. And another objective of this research is to identify association between numeracy, so we focused on numeracy, and the preventive health service utilization among middle-aged and older adults in the United States. So what we mean by middle age is 50 years and older. So this research is sort of framed with two different thoughts. One is the health literacy. It's a set of skills to obtain, understand, and use health information in order to make good health-related decisions and then navigate in the complex healthcare systems. The other framework, if I have time, I will get to that. And then numeracy, since this is a PIAAC conference, I believe all of you are familiar with literacy numeracy, so I don't need to repeat that. So in this research, we use the literacy and the numeracy skills as indicator of health literacy. The rationale is without basic skills, it is nearly impossible to have sufficient health literacy. So we are just using this literacy and the numeracy as an indicator of health literacy. So what we are measuring is obviously missing few important components of health literacy, but this is just our attempts. And surprisingly, there are significantly more literacy-related research than numeracy research. So this, particularly the role of literacy in a health-related context is underexplored. So that's we'd like to address. So based on the literature review, we are confident that numeracy should be predicting preventive health behaviors. Some of the reasons include numeracy determines your risk and benefit perceptions in a health context. So if you can understand the risk and the benefits for both short-term and long-term, that should be reflected in your behaviors. And nowadays, because of the advancement of information technologies, we can access to a wide range of a large amount of complex health information. So the numeracy plays an important role to tease out which pieces of information would be useful for your health behaviors. And sufficient numeracy skills, according to the recent, latest wave of PIAAC, only about 9% to 10% of US adult population has the highest proficiency of numeracy. And since aging is associated with poorer health and a lower numeracy, and this particular age group, the second half of adult life, has not been quite explored. So this is what we wanted to do. And then just to give you some heads up, I was pretty confident about this relationship, but it turned out that I was wrong. So we used the PIAAC 2012-2014 data. Let me correct. What we mean by middle age is actually 45 plus. That was a different study. Sample size was nearly 3,000. We looked at the 4 different outcomes. That's sort of common for both men and women. Some of the preventive healthcare utilization behaviors are specifically for men and women separately, so we did not look into that. Predictors include numeracy proficiency levels. So we tried the continuous numeracy scores as well as different groupings. So the 5 levels of numeracy, 3 levels combining lower end and then higher end, and also low versus medium and high proficiency. So this is more of an exploratory analysis. And the covariates include literacy skills, as well as socio-demographic, socio-economic factors, including, in addition to health status and health insurance status. we use the IDB analyzers, and I'm sure that all of you are familiar with this method, so I'm going to skip this, and we use the binary logistic regression. And this is just the descriptive statistics for the health, preventive health behaviors, flu shot, the dental checkup, and vision screening, and osteoporosis screening. So here's the results. So as I said, we didn't find the relationship between numeracy and the most of preventive health behaviors, except for one. But before we get to that, we identified the dichotomous numeracy level, comparing the lower end versus medium and the higher end was the most useful cut point when it comes to the preventive health behaviors among middle-aged and older adults. And other numeracy levels did not quite predict preventive health behaviors. And then, so luckily, we identified one association between numeracy and the dental checkup. So that was our main findings, and the rest of them are known findings. So that was the very brief results section, but unfortunately, that's all we have. And the meaning for numeracy cut points, so this is the research question. Objective number one was we argued that dichotomous measures. So comparing the lower end of the numeracy skills versus higher seems to be related to the preventive health behaviors, specifically a dental checkup. So the numeracy may be, so this is more of a baseline exploratory analysis. So numeracy seems to be useful to predict very specific type of preventive health behaviors. So overall, this sort of baseline analysis at the empirical evidence of understudied topics and the subpopulation, specifically numeracy and preventive health behaviors among middle-aged and older adults. And based on our literature review, there are not too many nationally representative findings. So this seems to be a fairly simple analysis, but still kind of lays the foundation for the future research. Numeracy measurement and the risk communication in healthcare. So this could be one of the preliminary implications for practice. So it's hard to connect such exploratory preliminary findings to actual practice, but sort of looking for the future, these findings might inform health in the healthcare settings to emphasize the importance of assessing the patient's numeracy skills, not only at the hospital settings, but in the community settings as well, and how we communicate the importance of preventive health behaviors. So the future research should definitely look into why numeracy is associated with specific type of preventive health behaviors, dental checkup. We still have little idea about why these two things are connected. And also the subgroups, there might be a gender difference, race, ethnic group differences, differences between across socioeconomic status. So this has not been explored enough. And also some practical issues. So we can just say we should assess numeracy skills in healthcare settings and community settings, but how do we do it? We still have little idea about how to do that based on literature. So that type of practical assessment tools, as well as practical intervention program, needs to be developed. I'd like to acknowledge that this research was partially funded by IES as well as AIR through a grant on NCES. So we'd like to thank for this support. And I kept it very simple, but I would be happy to answer any questions later on. So this is my contact information, and thank you very much for your attention.
Good afternoon. I'm Phyllis Cummins, and I appreciate the opportunity to share our research, Takashi, Yamashita, and myself. And I should have had Annabelle Arbogast's name on here. She's a, excuse me, a doctoral student at Miami University. Just by way of background, middle-aged and older adults are an important segment of the U.S. labor force. They represent between 40 and 50% of the labor force, and it has been increasing over the last several decades, partly because middle-aged and older adults are remaining in the labor force at older ages, but a lot of it has to do with the co-workflow. The baby boomers are aging, so they're now in these older age groups. And as we all know, the technological advances really require ongoing skill upgrading in order to be competitive in the labor market today. So it's important that adults of all ages participate in lifelong learning activities. Previous research has really not focused on this age group, and because of the supplemental sample that included adults 66 to 74, that gave us this opportunity. And even the 45 to 65 age group, there's not been a lot of research on adult education and training for those age groups. So this research hopefully fills that gap. The purpose of this study was to examine the associations between key human capital indicators and employment in the second half of life. And the human capital indicators are participating in formal and informal learning activities, and as I mentioned, our focus is ages 45 to 74. We will discuss 3 research questions today. Lifelong learning by employment status. Are there differences in participation in adult education and training based on employment status? And that's employed, unemployed, and out of the labor force. Literacy skills and use by employment status. Are there differences in literacy skills or use of reading and writing skills at home based on employment status? And use of reading and writing skills at home, and we'll talk about that a little more, that's really a proxy for informal learning activities. Literacy skills and use by retirement status. Are there differences in literacy skills or use of reading and writing skills at home among the retired, employed, and unemployed? So the key variables we looked at included demographic characteristics, age, education, and then we looked at employment status, as I mentioned, and health status, literacy, participation in lifelong learning activities, and skill use at home. The indices for skill use at home are derived from a series of PIAAC survey items. And examples, and we've heard this a few times yesterday, but reading books and newspapers at home, and just general activities that really are an indicator of informal learning activities. So as Taka mentioned, we used the SAS Map Grow program to account for complex survey design, weighted descriptive statistics, and binary logistic regression. Taka did the data analysis, so if there's questions, he'll address those. The findings from research question 1, overall, and this is no surprise, the employed participate more in adult education and training than the unemployed or out of the labor force. For all employment groups, people with higher levels of education were more likely to participate in AET. And this just shows it graphically. And there was a significant difference, as you can see, between those with less than an associate's degree and those with more than an associate's degree. So for those with less than an associate's degree, about 50% of the employed participated, whereas 81% of associate's degree or higher participated. And then for the unemployed, it was 33 compared to 62%. And the out of the labor force was 16 compared to 37%. So there were significant differences for those with less education, and in many respects, those are the individuals most in need of participating in lifelong learning activities. So findings for research question 2, literacy skills and employment status for ages 45 to 64. That should be 65 actually. I thought I fixed that. The employed the unemployed and out of the labor force had significantly lower literacy scores than the employed. The employed was our reference group in this example. So compared to the employed had roughly average scores of 280 for literacy, unemployed 260, and then out of the labor force 272. Reading and writing skill use at home, 45 to 65, I got the ages right there. There was a significant difference between the employed 2.11 and retired 1.93, and the higher index score is better. That means they participate more in skill use at home. So there was a significant difference between the employed and the retired. There was no significant difference between the employed and the retired in reading skills at home. It was just writing skills that was the significant difference. So here's a graph showing the information. Retirement for research question 3, literacy skills and retirement status, age, and I did it again, 45 to 65 it should be. Retired and employed had significantly higher literacy scores than the unemployed. Unemployed was a reference group in this case. So employed average literacy score of about 281, and the unemployed was, as you can see, substantially lower. So reading and writing skill use at home and employment status ages 66 to 75. There was no significant difference between employed and retired in use of reading skills at home, and there was no significant difference between employed and retired in the use of writing skills at home. We weren't able to look at the unemployed because the N was too small for the 66 to 75 age group. So policies and practices implications. It's really twofold. It's not just about providing opportunities for lifelong learning for older adults, middle-aged and older adults. It's educating them on why it's important, why they should be participating, and why, in order to remain employed, that they are going to need continuous skill upgrades with technology increases. A lot of older adults must remain in the labor market for financial reasons, with the change from defined benefit to defined contribution pension plans with Social Security. Retirement ages increase. For many, it's a necessity rather than a choice to remain in the labor market. And I think that's my last slide. I think you all have contact information for Taka and me in the program materials, and I would like to thank AAR and NCES for this opportunity and for funding our research. Thank you.
Good afternoon. Are you still awake from lunch? It is, it's great to be here. It's nice to see all of you. Independent researcher, what does that mean? Well, up until 5 months ago, I was with the U.S. Department of Education, Career and Technical Education, the Office of Career and Tech Ed. And a lot of my work was in the area of the research initiatives and our investments and our interest in literacy and career and tech education. So when Jaleh was reaching out to try to catch me, I had already left the office. So she said, I need a bio for the things. Like, well, what do I say? Retired, or former federal employee? So anyway, so that works. Thank you both for your papers. I thought they were very interesting. And a little surprising. So this is like the third year of PIAAC research studies. 300 papers have been written. And I think we kind of have a sense on the relationship of literacy and numeracy and other indicators or variables in there. So when I opened up the two papers, the first thing I did was sort of write down a couple assumptions I had before I even read the paper. So I assumed that there was a positive relationship between literacy and numeracy and a bunch of these other indicators such as income, employment, education. Yes. The other thing is I assumed is because there was a correlation, 0.8 correlation between literacy and numeracy, that there would be a similar, maybe a little less relationship between positive numeracy scores and a variety of the health indicators that would be in the paper. Surprise, surprise. That wasn't what we found. That wasn't what was found in the paper. So it made for interesting reading. So thank you. Now, before I get too far into this, I also want to admit my bias towards strong theoretical models and theoretical rationales as underlying research efforts. So some of my comments will sort of reflect that. I think the job market is, as they explained, for older people kind of dynamic. It was more so during the Great Recession, when there was a big push out of people with moderate to lower skills, and there was a sort of increasing of the requirements of people who did retain in the job market or who were hired. Peter Capelli talks about the fact that they even increased requirements to the degree that silly things were stated, such as if you wanted to work a cotton candy machine, you had to demonstrate prior experience. I mean, you had to have documented prior experience or you couldn't get a job doing the cotton candy machine. Well, that's silly. So now as the employment picture has improved, and now we're moving towards larger and larger groups of people being employed and retaining employment, there are questions as to what are the skill sets required. And I think Phyllis has done a very good job in terms of capturing sort of that question within this paper that she had. Now, one of the things I know, we tend to come to the research questions with our own sort of what the data provides us. So we say things such as low literacy is associated with worse physical and mental health. But it may not, and so there's almost an implied relationship, not causation, because we're smart enough to know that correlation is not causality. But still, there is that sort of equation in our mind that comes up. And I wonder if we need to think more about sort of the reciprocal determinism of health and literacy and numeracy. It may be that poor health is as much a driver of literacy as literacy is a determinant of poor health. So I say that because I kind of continue to remind myself that it's not always what the language leads us to believe. A quick comment on the relationship of AET, adult education and training, and the notion that the more employed participate, the people who are more employed participate in AET than the unemployed. All training has a cost. There is an opportunity cost and a dollar cost associated with it. So even if the training is free, you still have to, if you're unemployed, maybe get a babysitter, or you have to get on the bus, or you have to expend a certain effort and give up something to enable to get there. If there is a cost, that's another barrier. One of the things that we've seen is that often for the employed, the employers pay the cost, and there's very little opportunity cost because often training is at the workplace, especially if it's required, or time is given for that in lieu of the training time. So some of the explanation that may differentiate between the fact that employed people have more training than unemployed could be explained merely by the nature of the cost structure itself. There is a variable in PIAAC, DQ11, which actually asks formal education, grant from employer. Did an employee or prospective employer pay for tuition or registration, exam fees, expenses for books, or other costs associated with your studying for this degree? I didn't see whether that was actually used as a covariate or as in part of the analysis, but I think it would be interesting to take a look at both that variable and also its corollary for an examination for the prior year, BQ16, to see if costs then differentiate participation in AET. Even for those who are employed, education is not equally distributed. In our work that we've looked at career and technical education, you can see we've read studies that show that people who are at entry level and the lowest level of employment do not get the offers of training as the higher level employees do. And the rationale for that has been, well, if we train these people, then our competitors will come and poach them away from us, and we've spent all this money to train them for someone else. And it's interesting because even though that may or may not be true, that's not the rationale given for those who at the higher levels of income or higher levels of the organization. They don't say, well, if we train our assistant vice president, someone's going to come and steal it. So it's kind of a strange rationale that's given at that level. The other thing that we know, and it's been repeated in some other papers, is this notion that sort of the Matthews effect in education. Matthews effect in reading, Stanovich talked about, and Burton actually came up with the notion before him. And I think I'm going to repeat it again when I talk about the numeracy paper, but there are, I think, Matthews effects in education, and there are what Pat Cross called the chain of response in education. I think Pat Cross would be very pleased to see that the PIAAC data actually validates her theoretical model. And she had said about the chain of response, in which participation in a learning activity, whether in organized classes or self-directed, is not a single act, but the result of a chain of responses, which is chain of response, each based on an evaluation of the position of the individual in his or her environment. So people who have successfully negotiated education participate in more of it. Conversely, people who have had negative experiences in education find reasons to exit out of it or decline participation. So in the theoretical model suggested by the chain of response, we would not be surprised to see those people who have less education to have even less. So as we move toward the challenges that Phyllis has suggested that we need to take a look at how to improve this, we need to think about modifying that. Now, I want to move very quickly to the numeracy paper. And I want to reflect first that we have a numbers problem, or rather we have a problem with numbers, and that is, whereas very few people who consider themselves well-educated would profess, without embarrassment, that they are illiterate. They would say, oh, I can't read. Many of us are very willing to state that, well, I'm not so good with numbers. So, we need to change the narrative or change the explanation of what it is to be literate, both in terms of numeracy and literacy. So excusing the notion that, not being facile with numbers is okay, is not okay. And I think, just as I've stated before, I think there are significant Matthews effects with respect to learning numeracy, and they're much more challenging, I think, than mere literacy. We get, throughout the day, we see so many instances in which we read that we get thousands of hours of reinforcement of literacy, so that the objectivity of the process is very, very well established, not so much with numeracy. So now looking very quickly at the relationship between the health questions and the numeracy thing, and why it may be confounding in its findings. I could not find a theoretical model that suggested why these health questions. I could not find a conceptual framework for the health questions. And at its very basic level, how do these things relate to health? Do the presence of these manifest that someone who has them has better health than someone who doesn't? Maybe in a general way, but I couldn't find any solid research that suggested. So I think we need to, or for those who have poor health. So I think at one level, we need to be thinking about the kinds of research we need to validate the questions that are put into survey instruments such as this. How do we know that they really tell us what we want to know about health? Finally, there was one other thing. Going back to opportunity costs, I was looking at table, you don't have it, but I have table 3.1, which I was looking at the changes in responses. And one of them I noticed was that age 60, 65, there was a 12% jump in flu shots, 10% increase in screening, and osteoporosis screening increased by 7. What happened then? Why that 60 to 65 group experienced such a jump?
Medicare.
Yes, Medicare. Those of us from 65, yay me, have access to insurance. And so it may be that, again, cost is the determinant of participation. There is a variable in there for health insurance, and in the summary it said that that was one of the variables that was used in the covariate analysis, but when I looked at the paper I couldn't find it. So if it's there, maybe we need to raise that a little bit more. Finally, I want to end with this notion of the data we look at tends to be somewhat, we approach it as a continuous stream of data, and it is for the most part for the numerical scores, both in the numeracy and for all three measures. But in fact, I think the populations are quite different within the subpopulations, and I would say that it's time now, after 3 years of study, to do more of what, more of the latent variable analysis, more of the structural equation modeling that might tease out the latent variables that lay behind some of these, so we can see whether these are differences of kind and not differences of degree.